All right. So Len texted me late last night. He won't be able to join us this morning, but we can go ahead and get started. I think most of you know Kiran, Kiran Kaur, one of our second year fellows. She's going to be talking to us about non-allergic rhinitis and evidence of local allergic rhinitis. So thanks, Kiran.
Thanks, Drew. Hi, my name is Kiran. Everybody may see my long name on the screen, Kiran Kaur, but everybody calls me Kiran. I'll be turning off my video just to make sure there's no interruption with the presentation. It just has happened in the past, so just making sure. I'm turning my video off for now. So this is quite a broad topic. When Dr. Altman gave this topic to me, I didn't realize it's a Pandora's box. So there's a lot of subtypes, phenotypes, endotypes. So bear with me. I know this is it can be a bit of a dry topic. It's so early in the morning, but I'll do my best. So my topic is non-allergic rhinitis and evidence of local allergic rhinitis. I have no disclosures. And I would like, I'm requesting, please everybody mute their mic. I'm supposed to say that in the beginning. Okay, our objectives are quite broad. So we'll be covering a review of non-allergic rhinitis phenotypes and pathophysiology, which is actually not very well known. A review of management and discussion of the evidence of local allergic rhinitis, evaluation and treatment as far as some recent studies. So looking at rhinitis in general, we have to look at it as a big picture. We have to include allergic rhinitis as well. I don't think I can talk about rhinitis without discussing some allergic rhinitis. So it's a pattern of symptoms as a result of nasal inflammation or dysfunction of nasal mucosa. And I got this classification from the recent publication of the Rhinitis 2020 practice parameters. And this is the same definition that they used in 2008. And this is the same definition used in the ARIA guidelines, which is the allergic rhinitis and its impact on asthma, the acronym for that, in case the fellows didn't know that. So symptoms, as we all know, are one or more of the following, which is nasal congestion, rhinorrhea, anterior or posterior, sneezing, nasal itching, frequently eyes, ears, and throat are involved. The pathogenic mechanisms can be further divided into allergic or non-allergic, and different phenotypes are allergic rhinitis, which is what we see very commonly, non-allergic rhinitis, further broken down into with and without inflammation, mixed form of that, and then local allergic rhinitis, or sometimes called entopy. Now, is this a subset of non-allergic rhinitis or an independent phenotype? That's the question. And then there can be conditions that may have overlapping symptoms with rhinitis, and I've listed several below with chronic rhinosinusitis, with or without nasal polyps, CSF rhinorrhea, ciliary dyskinesia syndrome, deviated nasal septum, or several structural abnormalities, or reflux in general. So rhinitis in general, if you look at allergic rhinitis there in the United States, 10 to 30% of adults have this diagnosis and up to 40% of children. Now, physician confirmed is 14% of adults and 13% in children. I think people are often probably treating this at home, not coming in as much. Canadian population has higher prevalence. 20% of the population is diagnosed, it has a physician diagnosis. Could it be they have different healthcare system, more access, it's possible. Specifically, chronic non-allergic rhinitis is expected to, I was surprised to see 17 to 52% of adults in the USA. Worldwide, it might be 200 million people, it's unclear. And in 34% of our patients will have a combination of different rhinitis. And this definitely affects quality of life, and I think a lot of our patients come in just for that reason. 35 to 50% of adults report that nasal allergies have at least a moderate effect on their daily life, and that makes sense. So some of the quality of life measures that have been looked at, and these will later be discussed in rhinitis classification and monitoring how they're doing. Disturbance of sleep and falling asleep, staying asleep, and this takes it into the next day for daytime somnolence, fatigue, irritability, depression, unable to function physically in the social setting, and then having attention and learning deficits. And all these, I think, are very interconnected. There has been some association with anxiety and mood disorders. I didn't dig too deep into this, but I can see how this could, again, associate with the quality of life measures. Decreased smell, a sense of smell in allergic and non-allergic rhinitis can significantly affect your quality of life. And I've listed a few things below. Fun things in life as food flavors, you can't taste those, or you're adding too much salt or sugar to your foods to enhance flavors, which can lead to other adverse health effects. And then something dangerous is not detecting a natural gas leak. I guess that's a pretty significant thing to add there. But looks like that there is limited data available on other quality of life issues in non-allergic patients. Specifically, rate of reduction has been noted in patients with a NARS diagnosis, which we'll talk about later, which is basically non-allergic rhinitis with eosinophilia syndrome. So this is very expensive. Long-term, if you really add up all the over-the-counter costs, seeing multiple specialists, seeing allergy and then ENT and so on, significant loss of work and school days, decrease in productivity due to, for example, lack of sleep. And I mentioned a couple statistics there for you. So going forward, the way I've structured my presentation is really based on the 2020 rhinitis practice parameters, just to keep it more clear. And also, I think that is something you all probably have looked at. And that was published in 2020, like I mentioned. It was the contributions were from Joint Task Force on Practice Parameters and work group from Quad AI and the college. So going on with there's also the classifications I'm about to mention apply to all sorts of rhinitis. So severity, frequency, exposure is what we look at. Severity is divided into mild when symptoms do not interfere with your quality of life, and moderate to severe when you have worsening of symptoms interfering with the quality of life. So the most accepted division is dual, because that is what I guess is mentioned in many clinical trials. But I think on a day-to-day basis, we do use all three classifications. And we do document frequency where intermittent is considered less than 4 days a week or less than 4 consecutive weeks a year. And persistent would be more than 4 days a week and greater than 4 consecutive weeks a year. So how do you classify a patient that has the symptoms a few days a week all year? So they would be persistent category. Then we look at temporal patterns. Are they just visiting a friend's home where there's a pet? Maybe that's an episodic occurrence. So these breakdowns of seasonal perennial are what FDA uses to approve their medications. But in reality, patients can have both of these. Here's a simple breakdown of what we're looking at. So chronic rhinitis symptoms. Patients, often we go with history and we go on to check, their specific IgE or skin prick testing. And then this is a very nice breakdown of if it's negative, where do you go with that? So we don't do nasal allergen provocation test, at least commonly in the United States. But if we were to do that, that would be the best way to identify local allergic rhinitis versus non-allergic rhinitis, and we'll talk about that. So let's go right into what is non-allergic rhinitis. I think basically it defines itself. It is an entity which is independent of an IgE mediated mechanism versus what allergic rhinitis would be. Some of the phenotypes are, which we'll go over, vasomotor rhinitis, and I put down a couple other names it's been called: non-allergic rhinopathy, idiopathic rhinitis, infectious rhinitis is the next one, food-induced rhinitis, and there's further subtypes, hormonal rhinitis, drug-induced rhinitis, non-allergic occupational rhinitis, atrophic rhinitis, and NARS, and rhinitis of the elderly. These all come in acute and chronic forms. Patients tend to be older in general and tend to have severe congestion and rhinorrhea as their main symptoms, and they are less likely to have asthma. I like this diagram because it nicely shows the way most of the articles I have looked at, that dividing the rhinitis into classifications into phenotypes and endotypes. If you look at the left side of the screen, there's the IgE-mediated background. In the middle is they're dividing into neurogenic causes, and at the very right side, the non-IgE-mediated inflammation. So most of these diagnoses I'm going to talk about may overlap the neurogenic and non-IgE inflammation. At the top, obviously, unknown mechanism, we have to have that, and structural abnormalities. So starting with phenotypes, vasomotor rhinitis, we'll start with that first, which can be acute or chronic. Patients tend to have symptoms after they're exposed to temperature or humidity changes, which can be cold, dry air, airborne irritants. They're around perfumes, tobacco smoke, not necessarily of themselves or even their neighbors, as we've seen in clinic, or due to exercising. These symptoms can be variable, commonly similar to what I mentioned before. They tend to have nasal obstruction, increased clear secretions, and coughing due to those secretions. Less commonly, sneezing and pruritus. This is a diagnosis, basically exclusion of other forms. Again, history is most important, and I'll keep bringing that up. History is probably the most important part of our examination, diagnostics, as physical exam may be normal or vary. So skin prick testing and specific serum IgE testing is helpful to exclude allergic rhinitis. If history doesn't indicate a need to test that, we have not tested that in the past. Some patients, we just went on to medical therapy, but I'm just going with the parameters I'm mentioning. Nasal provocation challenge to determine hyperresponsiveness has been done with cold air or hypertonic saline. But again, that's in the research setting. So pathophysiology generally is not fully understood. So I'm going to go over a bit of detail of what are the thoughts on this. So evidence is, there may be evidence that it involves our neurogenic pathway with an increase in neural efferent traffic to the nasal mucosa and having an imbalance between the parasympathetic and the sympathetic nasal innervation. Based on this is based on noted beneficial effects of ipratropium bromide, so basically anticholinergic, and Vidian neurectomy, which I'll mention next. So Vidian nerve, actually, if you look at a lot of diagrams, because I was really looking for a good picture with a Vidian nerve, it's actually the nerve of the pterygoid canal. It is present right before the ganglion that splits into the parasympathetic and sympathetic nerves. And that is where they do the procedure. Neuro procedures, which I didn't note here, but they are available, which involve cryotherapy, which is way more anterior, actually can be an in-office procedure with similar effect, but I think the Vidian nerve neurectomy is a bit more aggressive. So patients with vasomotor rhinorrhea tend to have predominantly rhinorrhea, which appears to be enhanced with cholinergic glandular secretory activity, which can be reduced with atropine or ipratropium bromide. So this version may be called cholinergic rhinorrhea, one of the mechanisms possibly. Now, patients that have predominantly nasal congestion appear to have nociceptive neurons that have heightened sensitivity to stimuli, such as temperature changes, airborne irritants, even very yummy foods, hot and spicy foods, alcoholic beverages, and a few of the things I mentioned before. So this has been looked at with measurement of neuropeptides, such as substance P, in response to hypertonic saline and cold air provocation. I promised I would put some diagram here explaining what I just talked about. So if you, this diagram is actually useful to look at many, this will come up over and over. So I just want to discuss this at the beginning. So if you look at the very top of the image, there's exogenous activators. They have listed several, and a few of the ones I want to point out are like osmotic things that patients may encounter in their workspace. Alcohol, smoke, cold exposure, and other occupational exposures. So these basically affect our TRPV1, which is listed right below the epithelium there, which is a transient receptor potential vanilloid 1 receptor, which has been extensively studied. And that basically goes on to if you look way below, it says endogenous activators. So that's where it activates the ion channels. So what's happening here is thought is the TRPV1 along with ion channel activation affects the nociceptive C fibers in the trigeminal nerve, leading to hypersensitivity of these ion channels. So that is just a simplified picture of that. On the right side, there's also TRPA1, which is I'm not sure, somebody's mic is not on mute. Transient receptor potential and Kiran 1, which is TRPA1. So these are also being looked at, but they are less defined. And we'll talk about those. I wanted to put another picture here because I think pictures are worth 1,000 words. So I discussed earlier, if you look at the right side of the screen, the nerve of the pterygoid canal, which is basically the video neurectomy site. So as you can see, it's pretty posterior. That is where the procedure would be. In the middle is the sphenopalatine ganglion. So the neuro procedures work anterior to that, anterior to the ganglion. So there's conflicting research based on response to intranasal capsaicin, which is a selective TRPV1 receptor agonist. And it suggests that, what I just discussed earlier, that the nociceptive C fibers in the trigeminal nerve are which lead to hypersensitivity of the ion channels, and then leads to basically increase in irritation of the nasal mucosa, resulting in symptoms of vasomotor rhinitis. In clinical studies, when compared with controls, patients with irritant rhinitis have higher TRPV1 expression in the nasal mucosa and higher concentrations of substance P, which is a neuropeptide, in the nasal secretions. So the question is, should this be called neurogenic rhinitis? So we just need more studies for that. I'm going to briefly go over infectious rhinitis because I think we are all quite familiar with this, but this is a subtype. Acute or chronic presentations present or a clinic. So often it is self-limited rhinitis secondary to viral URIs, but it can also be severe fungal disease, for example, in immunocompromised patients, and you just look at that according to your patient population. But I think one thing to point out is in young children, viral URIs are the cause of 98% of these acute infectious rhinitis symptoms. Now, these can develop into bacterial rhinosinusitis with progression of symptoms that I have listed, which include mucopurulent discharge, pain and pressure, headaches, acute olfactory disturbances. Now, I should also look at the timing of these symptoms to see if there's I think we are all pretty good about distinguishing, at least in the allergy world, of allergic rhinitis versus these symptoms, or differentiate it. So the question is antibiotic prescriptions, right? So antibiotic prescribing rates are pretty high, 69 to 79%, despite lack of benefit, because it is difficult to distinguish between viral versus early bacterial rhinitis. CT findings can be similar also when you have a common cold versus having rhinitis symptoms. So it is best to defer CT scanning until the patient's acute symptoms have improved. Nasal culture and cytology of nasal secretions also provide minimal assistance in distinguishing, and it's also pretty much the person who does it, it's driven by the type of secretions collected, but it is not recommended. Again, we should defer antibiotic therapy for at least 7 to 10 days, but you should look at the clinical picture of the patient. But if you want to learn more about this, I didn't add it in here, but there's publications just regarding antibiotic therapy. I just want to point out differential diagnosis in children would be a bit larger for infectious rhinitis. Do look at foreign bodies, discuss history. They can have impetigo, which is acute Staph aureus infection of the nares, which does require antibiotics, or it could be enlarged or infected adenoids. Let's move on to food-induced rhinitis, which I have divided into gustatory rhinitis and alcohol-induced rhinitis. We'll go over gustatory rhinitis first. So the main symptoms are clear rhinorrhea after ingestion of hot and spicy foods, for example. The mechanism, again, is considered to be neurologic, but reflux of the non-cholergic and non-adrenergic system. There has been no evidence of IgE-mediated food-induced rhinitis symptoms without presence of anaphylaxis symptomology. There are no published studies with so many oral food challenges done around the country, even in research studies that have produced isolated rhinitis symptoms. Specificity, as we know, of food testing is less than 50%, and you can have sensitization to a food. It doesn't necessarily equate to a clinical allergy. So it is not recommended to check for food allergies. Looking at oral allergy syndrome by itself, in the United States, there are not adequate amount of studies that have looked into this. I was surprised to see that. However, just to explain OAS a little bit, so symptoms can be itching, swelling, which are mild and often limited to the oropharyngeal area. So rare systemic reactions have been reported, but again, it's not recommended to look into food allergy here. Alcohol-induced rhinitis involves basically upper airway symptoms due to alcohol hyperresponsiveness, considered to be due to vasodilator effects, and that makes sense with alcohol ingestion. It is not an alcohol allergy. Nasal congestion is the most common symptoms, and then followed by rhinorrhea. And these symptoms have been reported in looking at a collection of rhinitis population, 14% of healthy individuals, 33% of asthmatics, and 75% of patients with aspirin exacerbated respiratory disease. Alcohol hyperresponsiveness correlates with severity of nasal inflammatory response. And so we see more responsiveness in patients, as I mentioned, so an NSAID exacerbated disease, or patients with CRS with or without polyps, with or without asthma. Versus, I misread that, CRS with nasal polyps with or without asthma versus patients that just have allergic rhinitis or CRS without nasal polyps. Again, as I've mentioned many times, clear triggering mechanism is unknown in this as well. There may be elevation of systemic cystinyl leukotrienes that have been observed following alcohol consumption. So symptoms may be seasonal or intermittent or concurrent with allergic rhinitis. For most patients, any alcohol beverage can provoke these symptoms, but it seems to be that wine is worse for patients with CRS without asthma. Patients have reported diminishing of these symptoms with aspirin desensitization. So I think the take-home point of this is, if you have above noted associations with alcohol-induced rhinitis symptoms, you should look into see if your patient has aspirin exacerbated disease or polyps. So you should look into getting a rhinoscopy, spirometry, and so on. Hormonal rhinitis can be seen at different stages of a woman's life. So there's in pregnancy, menstrual cycles, menopause, and puberty. It is also seen in thyroid disease. It's also seen in acromegaly. So the thought is it's due to estrogen and progesterone-induced changes, at least in the pregnancy and the other cycles, resulting in increase in nasal congestion. Increase of estrogen can cause nasal vascular engorgement, which leads to nasal congestion. So beta estradiol has been looked at. Basically, it can elevate expression of AH1 receptors of histamine on nasal epithelium and endothelial cells, which increases the eosinophils' migration to the area. Progesterone and estrogen can also increase eosinophil migration into the nasal mucosa, in contrast to testosterone, which decreases eosinophils in the nasal mucosa. I found that very interesting. In pregnancy, nasal congestion can be contributed to increase in estrogen, progesterone, as I mentioned before, but really the exact mechanism is not clear. It affects 20 to 30% of pregnant women, starts around 34 weeks of gestation, and it resolves spontaneously 2 weeks postpartum. the thought behind this is possibly due to vasodilatory hormones promoting growth, such as growth in breast milk production. So we're looking at prolactin production, insulin-like growth hormone factor production, placental growth hormones, and so on, which all exit after birth. So that makes sense. Hypothyroidism and acromegaly, I think the hypothyroidism mechanism is unclear, but acromegaly due to growth hormone makes sense. I want to discuss here some update from the practice parameters regarding safe use of medications in pregnant women. So a few prospective trials have supported evidence of safe use of pharmacologic treatment in randomized trials. So at this point, although all intranasal corticosteroids are considered safe, triamcinolone has been associated with higher rates of congenital respiratory defects in a large Canadian prospective cohort study. So besides triamcinolone, it's all right to use other intranasal corticosteroids. As far as usage for intranasal antihistamines in pregnant women, there's still little data, but it seems to be that overall oral antihistamines are considered to be safe for usage. So therefore intranasal antihistamines. Nasal saline has always been considered safe. Looking at oral decongestants, and these should be avoided, especially in the first trimesters, because there have been a few studies showing risks of congenital defects development. So, for example, I'm just brief overall mentioning of gastroesthesis, renal collecting system dysfunctions, pyloric stenosis, and endocardial cushion defects have been noted. So I think the main thing to get out of this is avoid oral decongestants during first trimester of pregnancy. Montelukast still carries a class B, which is the old classification of pregnancy classification, so it's okay to use. Going on to drug-induced rhinitis, which has its own breakdowns. So there's the systemic drug-induced rhinitis, which can be local, neurogenic, or idiopathic. Then there's the rhinitis medicamentosa, which is caused by different medications, and I will go over those. This can, as I mentioned, has its own subtype. So basically, acute inflammatory response is induced following ingestion of NSAIDs or acetylsils or aspirin. You can have isolated nasal symptoms or nasal symptoms as part of NSAID exacerbated respiratory disease with acute asthma symptoms, and this an association with CRS with nasal polyposis. So disruption of sympathetic, so medications that may result in disruption of sympathetic or parasympathetic tone by the alpha and beta adrenergic blockers result in rhinorrhea, nasal congestion. So I listed a few here: central acting sympatholytics and peripherally acting sympatholytics. Some things our patients may be using, and ganglion blocking medications and vasodilators. The idiopathic mechanism, so there's no clear understanding of the mechanism here, but many medications, I think this would be difficult to define because so many medications can cause so many nasal symptoms. So I listed several medications here. So I think the take-home message here is to check your patient's medication history. Overuse of topical decongestants, as we know, can result in rhinitis medicamentosa. Work-related rhinitis, there are also two types of this. So there's de novo occupational rhinitis, and it makes sense of patients being exposed from a particular occupational environment, and they're not usually in this environment outside of their workspace. Or there is work-exacerbated rhinitis, which is worsening of their pre-existing or concurrent allergic or non-allergic rhinitis symptoms while in the workspace. This is due to, most commonly due to high molecular weight agents, which are greater than 10 kilodaltons. So that would be plant material, organic materials, so plants, microorganisms, or animal debris. So this results in IgE and Th2 cell activation. This can also be due to, but less commonly due to low molecular weight occupational sensitizers such as cold, dry air, dust particles, smoke, transition metals. I didn't look up what that transition metal is specifically, but patients do come in contact with, they can come in contact with several of things I mentioned in their work setting. And this is without association with IgE-mediated action. Following a specific inhalation challenge, when compared with low molecular weight agents, high molecular weight agents produce significantly higher level of acute phase reactants, cell adhesion molecules, and endothelial growth factors. Work exacerbated, and I don't want to repeat that, sorry, I didn't realize I noted that there again. So basically, rarely single high level exposure or multiple low dose exposures of non-allergic irritants can result in chronic rhinitis or reactive upper airways dysfunction syndrome. This is something similar to what patients can develop. They can develop asthma symptoms in the same setting. This has been noted via nasal mucosa biopsies in exposure to chlorine dioxide. So pathological changes were noted, such as lymphocytic inflammation of lamina propria, epithelial desquamation, and increased number of nerve fibers. Next type is atrophic rhinitis, which can be primary or secondary forms. This is a chronic nasal condition associated with atrophy of nasal mucosa, and then paradoxical presentation with nasal congestion due to sensation of decreased airflow. And this is considered likely because due to result of decreased airflow resistance, feeling the sensation of nasal congestion. So primary pathophysiology is overall known. We really don't see this in the United States very much. It is associated with mucosal colonization, primarily with Klebsiella auxine, but other bacteria have also been seen. It's seen in young to middle-aged adults in developing countries with dry climates. Uncommon here, but I think it's important. We have patients here from all over the world. This is something to consider though, especially in the Seattle area. In one US study, it categorized 19% of rhinitis patients having primary atrophic rhinitis, and they were around the age of 52 years. So it is basically, as I mentioned before, atrophy of nasal mucosa, resorption of underlying bone and turbinates, nasal dryness, foul-smelling nasal crust associated with awareness of bad smell, and biopsy findings show squamous metaplasia, glandular cell atrophy, and loss of pseudostratified epithelium. These patients do not have history of surgery or trauma. Versus our secondary rhinitis, oh, I think I went too quickly. How do I go back? I don't know. But I'll discuss this with you. So atrophic rhinitis, which is secondary, is what we see most commonly in the United States, and it's less severe, and it's seen after usually excessive nasal surgery or patients that have trauma or irradiation. If a patient does not have history of surgery, you want to be looking at, is there an underlying inflammatory systemic disease going on, such as sarcoidosis or GPA even. And these patients complain of something similar to what we call an empty nose syndrome. So their nasal vault is empty because of the surgery or aggressive treatments. So they have a perception, though, of severe nasal obstruction and an inability to sense airflow through the nose. So they always feel congested. It's a paradoxical feeling. These patients tend to have normal exams consistent with their baseline surgeries, and they have normal or low nasal resistance on rhinomanometry. So both the primary and secondary patients I would treat with nasal saline rinses or glycerin-containing nose drops, basically just moisturizing the nose. And there are surgical interventions as well. Going on to rhinitis of the elderly, which I now look at many of our patients. Is this what their diagnosis is? Possible nasal hyperresponsiveness of the parasympathetic system. This is also considered neurogenic rhinitis endotype. These patients have profuse rhinorrhea, and it's responsive to anticholinergic treatments. And a lot of the changes are basically nasal physiology changes and body water contact decrease, decrease in nasal blood flow to the area, degeneration of mucous glands, collagen atrophy, So the treatment for this makes sense to be intranasal ipratropium. Second generation oral antihistamines and intranasal antihistamines, leukotriene inhibitors, and intranasal corticosteroids are effective and well tolerated, but we need more data on this. It is not recommended to use sedating oral antihistamine, especially in the elderly, for example, diphenhydramine, chlorpheniramine, and hydroxyzine. These anticholinergics can have other effects that the elderly already may be dealing with, such as urinary retention, constipation, delirium, ocular pressure changes, so just be careful with that. And this is seen with cumulative use of anticholinergic agents. And I meant to mention, there have been studies that have shown association of development of dementia with sedating oral antihistamines, so something else to be watching for. NARES is NARES is the next subtype. So this is the general consensus is we don't know much about this. So therefore, it's difficult to have a clinical criteria for this. So basically, it was initially named in 1981 after a case series of patients that were non-asthmatics, had perennial intermittent symptoms of profuse rhinorrhea, had paroxysms of sneezing, had nasal ocular pruritus, lacrimation, and nasal congestion, but they did not have complete obstruction. This study excluded patients with CRS with nasal polyps. They had done oral aspirin and inhaled methacholine challenge on few patients, and it was negative. Patients were found to have elevated nasal eosinophils of greater than 20%, but had absence of specific IgE serum testing and skin testing in majority of the patients. Other systemic evaluations have shown blood eosinophilia also, but I didn't find this as mentioned too often in my literature review, but apparently there is a blood eosinophilic NAR. NAR's prevalence is in 1 to 5% in children and 5 to 15% in adults with rhinitis. What in children, for example, nasal eosinophilia has been seen to persist even without allergies throughout the year, even when they're not exposed to the allergen that they normally would have symptoms to. Nasal biopsies from these patients have shown increased eosinophils, as well as increased number of mast cells and predominant mast cell degranulations. There's other cytology showing neutrophils too. So there's, depending on what article you looked at, there were also predominant mast cells and neutrophils. So I think this is a mixed bag diagnosis. Differential diagnosis so just persistent nasal eosinophilia, it can be many things. It could just be allergic rhinitis, local allergic rhinitis, CRS, a granuloma, or allergic fungal rhinosinusitis, NSAID exacerbated disease. So the problem with this is how do you quantify nasal eosinophilia? So there are lower limits of nasal eosinophilia, which is required, and it's variable. It can be from 5 to 25%. It's questionable what kind of secretions you use. It is dependent on methodology of the nasal cytology as well, which can result in variable amounts of eosinophils. So basically, current clinical guidelines have not recommended routinely assessing for nasal eosinophils. But I guess the point of this is, regardless of the etiology or the mechanism, nasal eosinophils do contribute to direct mucosal damage. They can affect, they cause protraction of mucociliary clearance and result in nasal hyperresponsiveness. So patients still are miserable. So we should consider this diagnosis in patients who are non-allergic with prominent symptoms of perennial rhinorrhea and sneezing. They have absence of facial pain, nasal obstruction, or polyps by rhinoscopy. And they tend to respond really well to intranasal corticosteroids. So I just want to I'm not going to spend too much time on this. I think we all know how to do evaluations, but I just want to be complete and add this here. I think the most important part of evaluation of non-allergic rhinitis is history. So as I had discussed in the beginning, we would look at all the onset durations, timing of the year, as far as when their symptoms are, success and failure of therapies in the past, including over-the-counter, and comorbid conditions. Is there any atopy or asthma history? Consider spirometry and family history. All the histories I've mentioned are, I think, all contribute to further evaluation and treatment plans. So as far as a simple evaluation could be a validated 4-question screening tool or a questionnaire to exclude rather than confirm allergic rhinitis. I didn't see one. I looked for a questionnaire that we may use day to day just to do, like for a new patient diagnosis. I know we use a questionnaire to establish how therapy is going, but so the questions on that questionnaire, ideal questionnaire would be if the patient's greater than 45 years age, if late onset symptoms, have no family history of allergies, there's no seasonality of symptoms, and they have trouble with non-allergic triggers, they probably have non-allergic rhinitis. So that'd be a good questionnaire to have. This is just part of the practice parameters, looking at what to look for in clinical symptoms. So physical exam is basic physical examinations. Depending on what's available in your office setting, you can get very detailed. But of course, if there's further concern needing extensive evaluations, patients should have nasopharyngeal laryngoscopy or referral to ENT for structural or concerns for if there's a concern for there's a tumor. I think the purpose of the physical examination is to really rule out the more abnormal things and to get a baseline examination before you start therapy. We went over these as we were talking. So probably the most important thing in the initial diagnosis would be just to obtain a part of the history, serum IgE testing, specific IgE testing, or skin prick testing, just to rule out allergic rhinitis. And then there's decision tree according to that, which I mentioned earlier, will help you make better treatment plans. So part of the 2020 practice parameters, this is a very nice diagram of intermittent, and then the next one is with persistent non-allergic rhinitis pharmacological treatment for ages 12 and above. So basically, the reason they put the age greater than 12 is due to comparative trials are only done in this age group, but really most of the treatments apply to children younger than this age group. I would say except for oral decongestants, which under the age of 6 years are not recommended. The treatment plan basically goes by the VAS symptoms, which is a visual analog scale looking at evaluation of severity of rhinitis symptoms in patients and the degree of overall control, with 1 to 10 classification, 10 being the most severe. So if you look at the very top, that's what they go by as far as looking at mild versus moderate persistent symptoms. I have a few slides regarding non-allergic rhinitis treatment, which I'll try to go over quickly because I do want to talk about local allergic rhinitis. So basic point is we treat symptoms in non-allergic rhinitis because that pathophysiology is not well known. So you do what you can for the patient's improvement in quality of life. What works for the patient in their day-to-day settings? What will they adhere to most? So one thing that comes up is postnasal drainage, which is frequently not well controlled despite combination therapy, even with anticholinergics. So there's no double-blinded placebo-controlled trials showing evaluating therapy efficacy and safety of first-generation oral antihistamines. And I want to mention that here because first generations do have anticholinergic activity, such as chlorpheniramine. So the decision remains controversial if you want to add that to your patient's plan. These are more sedating, they can have higher risk of dementia with cumulative dosing. And then you have to be careful using this in your elderly population, as we discussed earlier. Oral leukotriene receptor antagonists are not recommended in NAR treatment because there's no mechanistic rationale, at least from what we understand so far. Intranasal antihistamines are recommended as first-line monotherapy option. So are so are intranasal corticosteroids. So depending on the decision tree, you can try each of the monotherapies, either intranasal corticosteroids or intranasal antihistamines, and either are fine as first-line options. One treatment I did want to discuss is intranasal capsaicin, which can be found over the counter. I tried looking for it at our local store. I didn't find it, but apparently it can be. It is a pungent compound found in hot red peppers. I think everybody knows that. It is a selective TRPV1 ion channel agonist. It reduces nerve conduction of nociceptive C fibers. So all the things we discussed earlier, it has been found to be helpful in reducing nasal hyperreactivity. However, it's not approved by the FDA for rhinitis. When using non-allergic rhinitis or mixed rhinitis, it does reduce a lot of symptoms. For treatment of idiopathic non-allergic rhinitis, the recent Cochrane analysis has found capsaicin improves nasal symptoms, and this can last up to 36 weeks after treatment. It's based on a few studies, but I think that sounds promising. And similar data has been seen in mixed rhinitis. We need larger, well-conducted randomized trials to look at this, to have more options for our NAR patients. And here's my INCS slide. I think I put them opposite when I was putting this together. But we know intranasal corticosteroids are very helpful, but it really depends on your patient. I discussed intranasal ipratropium several times through my presentation as commonly used to significantly reduce rhinorrhea symptoms in several subtypes. But the one side effect that is important is it can cause nasal dryness. And then the guidelines also go over combination therapy. And there's surgery and botulism, toxin injections that are other alternatives. I want to discuss local allergic rhinitis. I know we have a few minutes left. It's referred to as entopy. So cellular studies basically show that there is local, basically there's quite a bit of involvement of B cells and IgE production locally. That's the long and short of it. Which is very interesting because I don't think we look at this to target this entity by itself to treat patients. We see many patients that seem to have perennial symptoms, but their testing is negative. They tend to have negative skin prick testing or specific IgE serum testing. We don't do this in the United States, at least it's done extensively in Europe. But they tend to have positive nasal allergen provocation tests. Many of these patients tend to have conjunctivitis and or asthma, and that's an important association with local allergic rhinitis. These patients can have immediate or late response to the nasal provocation testing. Few patients have, I think 30 in this next study, some patients may have only local specific IgE in 30% of the patients. So I think we see discrepancies there. So just measure on specific IgE would be difficult to do versus looking at control of symptoms. Let's see here. And this is just a rough diagram of, I think we all know dendritic cells bring in allergens, and then, but this is all local. Okay. So going to LAR, currently is the nasal specific IgE is difficult to obtain. That's what I was mentioning earlier, that depending on how you obtain it, you may have low or high results. So how do you diagnose LAR? I saw that there is a recent method of detection via local application of ImmunoCap, which is sensitive 43% of the time. Potential for future usage, I don't think this is available right now. So other evaluations that can be done are the NAPT procedure, which is very challenging, very time consuming to be done in an office setting. And then basophil activation test is available, but it's more research based and it's very accurate. Just a rough diagram of what involves a nasal allergen provocation test is, I think, take home messages takes a lot of time. It would take a lot of staff to do this. In a population, I just want to go over LIR a bit more. In a population-based observation study that categorized all patients with rhinitis, over 25% of patients were diagnosed with LAR, 63% had AR. So some studies have also shown that maybe 100% of our patients with NAR have LAR, but we just have not looked at it. It's more prominent in women and patients with family history positive for atopy. And mean onset tends to be over a greater age of 21 years, generally. In patients with local occupation rhinitis, this is also a consideration. And this is probably one study that I think that is most important to mention here is study done by Rondon et al. And there's also a co-author, Campo et al. There are many articles just coming out of Spain with these two authors. So Rondon et al. Had two major publications in 2011 and 2018. So they did a study looking at prospective study looking at patients at 5 years and 10 years for follow-up. Their question was, should LAR be considered the first-line step in development of allergic rhinitis, or it's an independent phenotype? So their final cohort was 176 patients greater than age of 14 years, and they had 115 age and sex matched health controls. The age of 14 years was really because their center only had patients above the age of 14 years. They just didn't see any younger patients. That was a limitation. They only took patients that had onset of symptoms less than 18 months and had no other immunologic disease. They had yearly evaluations looking at clinical demographic questionnaires, basically looking at quality of life, how that's changed, and if there's any change in family history and so on. They had yearly spirometry, skin prick testing, and serum IgE evaluation on a set of allergens that they were looking at, including dust mites, their area, pollens, molds, and a few of the animals. And then they also did other evaluations at baseline, 5 years and 10 years, which included nasal provocation testing to dust mites, alternaria, and Olea europea, which is, I think, olive tree, and grass mix. And if they had any other specific skin test positive during that time period, they added that as a provocation too, but they didn't mention that much in their study. At 5 years follow-up, it was noted that patient had increased persistence of their nasal symptoms, which they saw that at 10 years, if they looked at the whole 10 years, the first 5 years were the worst development of symptoms. Patients had new association of conjunctivitis symptoms and asthma in 30% of these patients. So I just want to add that there are other studies also looking at local specific IgE. Is there a role in just conjunctivitis by itself or asthma by itself, just as a aside? They found that the rate of development of allergic rhinitis was similar to healthy controls at 5 years. At 10 years of looking at the 10th year, patients experience a significant and clinically relevant worsening of rhinitis, increase in emergency assistance. So they looked at ER visits for asthma as well as exacerbation of rhinitis and so on. Patients with development of asthma, they had new onset of cases in 12% of their patients. They also looked at allergic conjunctivitis symptoms, which progressed but did not significantly increase after 5th year. And loss of allergen tolerance to nasal provocation testing. A lot of these patients complained of impairment of quality of life. So what they found is that rate of development of allergic rhinitis with systemic atopy was similar in patients with LAR and controls. So then systemic atopy, which would be defined by skin or serum testing. 16 of these patients had to be withdrawn because around the 6th to the 9th year, they actually developed systemic symptoms with the positive testing. So they were moved on to the immunotherapy just to for compassionate usage. Throughout these years, patients use oral antihistamines, intranasal corticosteroids most frequently were used. But it looks like after 10th year, seems like the ocular symptoms were worse. So their patients were using ocular or oral antihistamines otherwise. There's a lot of data I'm not going to go over, but I summarized in the previous slide. Mainly they were looking at asthma and conjunctivitis in this and the medications usage. So from this, we can say that, again, we don't do nasal provocation testing in the United States. I wish we would do that, at least some centers. The mainstay is avoidance. Pharmacotherapy seems to be similar to allergic rhinitis. Recent well-controlled trials have demonstrated that if a specific triggering allergen can be identified, SCIT or SLIT are considerations, but it is not routinely done. A randomized double-blinded placebo-controlled parallel group demonstrated that SCIT with dust mite patients, DP specifically, with LAR who are DP sensitized, had significant reduction in their total symptoms scores or medication usage over a 24-month period. And some of these patients responded as early as 6 months into treatment. Other smaller studies have shown success with BERT, SCIT, subcutaneous immunotherapy. They may have had initial increase in local specific IgE, but after 24 months, it was a blunted response. Rondon et al. Has, as I mentioned, done other publications, similar publications to local allergic rhinitis. They found that in a randomized double-blinded placebo-controlled study with GRAS SCIT, it demonstrated that 7.4% of the active group versus 3% of the control group developed specific IgE to GRAS at the end of year 1 of their subcutaneous immunotherapy. So it is unlikely these patients are to develop systemic atopy, but we don't know. We need more studies. So I think that is the future. We need more studies for non-allergic rhinitis and local allergic rhinitis. So hopefully I covered everything. It was a lot. So word of the day is perfume, which fits well, I think, for our talk. Any questions?
Any questions from the group? No, Kiran, that was great. It amazes me how common this is and how much we don't understand about it. So
I know, I'm sorry. I didn't have a whole lot new of things to share.
no, it was a great review. So many different subtypes. So yeah, that's great. So if there are not any questions, Vinod.
Drew, this is Vinod here. Hey, thank you. It was a very good review of the, the main, at least one of the main things that we see as a practicing allergist, I would imagine. So it was very helpful. I had a question I had was, I didn't know if there's any more data when you look at the NAIRS, NAIRS syndrome with regards to, the question, the thinking was, we see our eosinophilic esophagitis. We do see there's an eosinophilic problem, and we do sometimes think there is a allergic influence. Of course, our skin testing is certainly not geared towards kind of figuring out what that could be, is there something similar that we think could be happening in the nose? That's not necessarily that they have esophagitis, but something similar that affects, allergy-wise, whether it's environment or food that affects the nose, but our skin testing is not as good to figure that out.
I looked at the European as well as the United States, the few studies. I didn't see that specifically, but I think it's a thought. I think we're missing a lot, but I did not see that.
Thank you. Maybe, this is Vinod here again. There's probably more a comment or just to clarify, I think you had mentioned about gustatory rhinitis and, kind of congestion issues. And I think we clearly probably know that there are probably patients that walk into the clinic and like, I'm really stuffy, I got this phlegm in the throat. I think it's a food allergy. I would imagine that's usually not a food allergy, but we do get, food allergic reactions. I think the implication, when you're talking was, probably they don't need food testing, but we do know there are, people who have had who do get anaphylaxis, that runny nose or rhinitis is one of the symptoms. So in a setting of IgE-mediated reactions, you can still get rhinitis as part of the, I think anaphylaxis, that they may be, unique set of patients that probably do need food testing because it's part of the food allergic reaction.
I agree. I was going by specifically the practice parameters where they're mentioning exactly what you said, that there just not have been studies that have mentioned just rhinitis as an isolated symptom. So there have been the whole set of symptoms other than rhinitis along anaphylaxis, systemic symptoms. I think those patients is worth looking into, at least part of the practice parameters. I know in real life patients would not be comfortable with us ignoring their worries. I think we do end up testing and it's the same food over and over to give them a peace of mind. We do end up looking into it. Practice parameters, though, do not recommend it. So I just want to emphasize that.
Thank you.
Thank you. All right. I think it's 8:01. I think we probably should wrap up. We have to go to other meetings. Is that okay with you, Drew?
No, that's great. Thanks, Kiran.
Thank you. Take care, everybody.